Okay, welcome everyone to the OLLI Medical Series. This is a weekly series where we invite doctors from the community in to give a lecture on different topics that are geared towards the senior population. Tonight's lecture will be on cancer screening test procedures as a whole. We'll talk about lung, breast, prostate, colon, etc. for seniors. It will also include some of the risks and benefits, who should have the test and who should not. Speaking tonight will be Dr. Matthew Keating and Dr. Daniel Kung. Dr. Keating is a UCI health hematologist-oncologist who sees a wide variety of hematology and oncology patients in an academic community setting. His training includes direct patient care for high acuity patients in the bone marrow transplant unit, as well as patients enrolled in various clinical trials, including CAR T-cell therapy for both solid and liquid malignancies. Dr. Kyung is a UCI health physician specializing in general hematology and medical oncology. As a general hematologist and medical oncologist, he sees patients with various cancers and blood disorders. His clinical interests include treating cancers of the prostate, liver, gastrointestinal tract, lung, head, and neck. So let's welcome our doctors tonight, and we'll get started with their lecture. So, Dr. Keating, Dr. Kyung, if you'd like to get started, if everyone would like to mute themselves and turn their videos off, it would make the presentation much nicer.
Whoops.
Young is muted.
Okay, hi. Can you hear me now?
Yes.
Okay. So thank you for having us. So
I can't understand.
Hello? Okay, so this is just our contact information. In case you guys have any questions, feel free to email us. And this will be provided again at the end, so you don't have to write it down or anything. So today's topic is about cancer screening. So why do we do cancer screening? The whole point of it is to detect cancer in asymptomatic patients. And when we find cancer, we can intervene, and that results in the decrease of morbidity and mortality. So when you screen for cancer, it actually doesn't necessarily mean we're going to find it or that we're actually diagnosing it. It identifies whether or not a cancer may be present, and at that point, if appropriate, we do additional testing. With cancer, earlier treatment, better the outcome. So the whole point of it is to find it early if it's possible. Usually, cancer spreads and grows, exponentially. So if it is present, finding it earlier is definitely better. But, unfortunately, it's not a perfect science. And although finding it early gives us better outcome overall, it doesn't necessarily always mean that it's always going to reduce your mortality per se. However, if we look at the general population, screening for cancer definitely makes a big difference. And I think you'll be able to see that through our presentation. Now, we've been working for decades on what ideal screening tests are, because sometimes it really makes a difference, but other times it actually causes more harm. You know, especially when we're overly looking for things. So I think you'll see what I mean as we go through the presentation as well. So this is a table. I'm not sure if you guys can see it well, but this kind of goes through the different screening methods that we have out there and some of the recommendations. You'll notice that there are different recommendations for different cancers based on different groups. So the three major ones are US Preventative Services Task Force, the Canadian Task Force on Preventative Healthcare, and American Cancer Society. The recommendations are similar in general, but there are some differences. There isn't one right way to do it, but these are similar enough that as long as you're getting screened based on one of these recommendations, you're in good hands. And we're gonna go through these individually, so it's okay if you can't see it. We're gonna start off with breast cancer. It's very common, and it's, you know, it's well known. And I think, especially for women, this is something that, you know, that a lot of people think about. And we do have very effective screening methods. So we have three things that we looked into. One of them is a self breast exam. The other one is a clinical breast exam where a clinician does the exams. And then of course we have the mammograms. You know, the self exams and even the clinical breast exams are actually falling out of favor just because it's difficult to standardize, you know, such a subjective exam. It is true that women know their bodies, you know, the best. So if there's something that, you know, you detect that is concerning to you, it's definitely important to let your physician know and get it evaluated. But you know, even the US Preventative Task Force is now recommending against clinicians on teaching women how to perform exams. You know, oftentimes the breast tissue can change depending on the cycle, for example, and sometimes there's a lot of benign tissue that can be thought of as concerning. So it does and can lead to overly invasive workup. So that's one of the reasons that we don't necessarily recommend a self-exam. But for example, for the American Cancer Society, women should know how their breasts normally look and, you know, report any changes right away. Same thing with the clinical breast exam. There's insufficient evidence to recommend adding a clinical exam per se. It does depend on a case by case basis, but it's no longer really recommended per se. Of course, if there is something concerning, a clinician should take a look. But in terms of evidence-based practice, it hasn't been shown to be very beneficial. Now, what we do recommend, and I'm sure you've heard, is mammograms. So it's a little different based on which group recommends it, but for the US task force, for example, it's recommended every 2 years for women aged 50 to 74. Before the age of 50, it's on the situation. So, you know, for example, if there is something concerning, then we would get it. If there's a family history of breast cancers, then that would be a reason to get it a little bit earlier. But overall, for the general population, before the age of 50, the US Task Force doesn't believe there's benefit per se. However, for the American Cancer Society, the recommendation is a little bit younger, annually starting at age 45, and then above the age of 40, they should at least have the opportunity. So it's a discussion to be had with the physician. And then over the age of 55, then we recommend transitioning to a biannual screening. And the clinical exam, again, is not recommended per se. So as you can kind of see, when the recommendations differ slightly, as long as you're getting regular mammograms and following with the physician and determining the screening interval based on your risk factors and your comfort level, as long as we're checking, it's okay. So regarding the self-exam, they're randomized controlled studies, and to date, it hasn't shown any reduction in breast cancer mortality. As expected, increased rate of biopsy, because if you're gonna find something that may feel abnormal, chances are we're gonna want to biopsy it too, just to make sure it's not cancer. And as a result, we do get more biopsies and we do find more benign lesions. And this is one of the reasons that it's not really recommended. In terms of mammograms, the general recommendation is average women with average risk over the age of 50, mammogram alone, or mammogram in combination with a clinical breast exam. Now, the breast exams, you ideally want it to be performed by somebody that with some regularity. So if a different clinician checks it every time, then it is a subjective exam. So ideally, the same person. And doing so, it does decrease mortality. And that's the key that we're looking at, because individually, it'll also improve your chances, but we also always consider the whole dynamics of the population. So the more people we screen, the more lives we're hoping to save. Now, always a little bit more controversial in the slightly younger population, 40 to 49. Part of it's because most women in this population is still menstruating. So with the hormonal changes, the breast tissue density can change. And sometimes the breast can be more dense, so the mammogram findings may not be as obvious. So it does result in more false positives. It does result in more biopsies, and that's why the official recommendation is at a slightly higher age. So 45, 50. Again, discussion to be had with your primary care physician. But the important thing is you are offered, and it's something that you keep in mind, and something that you want to make sure you're getting done. Now, there are high-risk populations, and in these women, we do offer an MRI for screening. Not all insurances, and oftentimes it won't be covered unless you're classified as high risk. Now, what is high risk? So there's something called a BRCA mutation that I'm sure some, if not all of you, are aware of. It's a mutation that predisposes you to certain cancers. Classically, it was known to be associated with breast cancer, but now we're finding that other cancers such as prostate and pancreas are associated with these mutations as well. So men can also have these mutations, but of course in the setting of breast affects women more. And then there are also these genetic tests for the BRCA mutation and other models that we use to determine a lifetime risk of breast cancer. So the Gale type Cusick, for example. So for these things, we basically have to get your family history, see what kind of cancers are in your family. We use your age, and we use these things to come up with a percentage. And then We use that to determine if you're at high risk of developing. And oftentimes we offer MRI. So for example, American Cancer Society will advocate the use of MRIs if you have over 20% lifetime risk. Now, MRI is useful because it is more sensitive. So compared to a mammogram or an ultrasound, we're able to detect things a little bit earlier. And again, early detection is key. So that's what we try to advocate for. However, the US task force doesn't officially recommend screening MRIs for women with just dense breast. So having dense breast alone doesn't really warrant an MRI. And again, that's due to false positives and lack of data. We're gonna move on to cervical cancer. Cervical cancer is another cancer that's actually very interesting, and we'll get into why that is, but it's another cancer where we can screen for, and early detection can lead to good outcome. So how do we screen for cervical cancer? We can use what we call a pap smear, where often a gynecologist will obtain cells from the cervix and they'll look for abnormalities. We can also test the cells and the cervix for HPV virus, and we'll get into why that's important, but we look for HPV viruses and their DNA because we know that HPV virus is responsible for majority of the cervical cancers. Now, as you can see, the recommendations vary a little bit, but in general, starting at the age of 21, and then pap smear every 3 years, pretty much until the age of 65, or you can actually combine the pap test with HPV testing, and because we're checking two different things, we can actually decrease the frequency of screening to every 5 years. And you can do that starting at the age of 30. So there are some nuances, and again, these are discussions that women have with their gynecologist or primary care physician to see what you're more comfortable with. If you're a little bit higher risk, typically we opt for screening a little bit more frequently. Now for the older population, women over the age of 65 who's had 3 or more normal pap smears and no abnormal tests in the past 10 years, and women who've also had total hysterectomy, they can stop cervical cancer screening because the likelihood is so low, it's not as beneficial. The Canadians, however, will screen every 3 years until the age of 69. So it varies, but the general idea is routine scheduled testing, pap smears and or the HPV DNA testing. So pap smear has been around for quite a bit of time, and it's allowed for the early detection of cervical cancer for 60 years. Now, the sensitivity is 78%, specificity is 62%. Not as high as you would like it to be, but we have to take into account it's a procedure, so there may be sampling errors. You would have to get the cells from exactly where the cancer is. So, it's always possible that a spot might be missed. You do have to preserve the tissue before it's tested. And then it's pathologic testing. So the pathologist looks at it. Sometimes it's open to interpretation. So that's why the numbers are a little lower than where we would like it to be, but it is certainly effective, and it is a tool that we have. And women with positive cytology, we refer for colposcopy. They'll do additional procedure to take out more and assess further. Now, the HPV DNA test, however, the sensitivity is much higher, about 90% for precancerous lesions. So it's recommended age 30 to 64. So you can do pap smear every 3 years. You can do the DNA testing every 5 years, or both every 5 years. But when you're younger, 21 to 29, we still recommend the pap smear every 3 years. Now, HPV vaccine has really gone into the mainstream. So now we're getting to the point where a lot of the population has had HPV vaccine, a lot of the younger population. So it does depend on the HPV vaccine type that you received. So we'll go into that a little bit more because historically, initially, there was a vaccine that protected against some types. And then later on, we developed another vaccine that protects against more types. So that's why it matters. So I thought you'd be interested in the HPV vaccine. Virtually, and why we recommend it. So virtually all cases of cervical cancer are due to the HPV infection. And HPV is it's a sexually transmitted pathogen that causes anal, genital, and oropharyngeal disease. And it can cause disease in males and females. Now, two types, 16 and 18, cause 70% of all cervical cancers worldwide. And there are these other types, 31, 33, 45, 52, and 58. These cause additional 20%. So you're looking at 90% of cervical cancers that are being caused by these specific HPV types. Because of this reason, a vaccine was developed to protect against the acquisition of HPV virus, its infection, and the resulting cancer. So it's literally a vaccine that was produced to prevent cancer. So in 1976, Harold Zurhausen hypothesized that the HPV vaccine virus caused cervical cancer. In 1983, HPV genotype 16 DNA was discovered in an invasive cervical cancer. The following year, Zurhausen and his team discovered the genotype 18 DNA. Between 1991 and 1993, various patents were filed to begin the production of a prophylactic vaccine. And in 2006, FDA approved the first HPV vaccine, Gardasil. If you look at the timing, it's really interesting because if you look at what's happening with the COVID-19 virus and how we were able to come up with a vaccine, it's really impressive seeing how long it took to produce this one. But the first HPV vaccine was Gardasil, and I'm sure you've heard the name somewhere. So who do we recommend the vaccine for? So routine immunization starting at the age of 11 to 12, but it really should be offered to anyone aged 13 to 26, those who haven't been vaccinated previously. Ideally, you want to get the vaccine before you become sexually active because HPV virus is a sexually transmitted disease. 2 doses if it's before the age of 15, 3 if it's after. And you see Gardasil 9, that covers all 9. Now this is very impressive. If you look, you can see the incidence of cervical cancer decreasing in the United States. And this is all due to the HPV vaccine. We're protecting women from the virus, and as a result, we're seeing less cervical cancers. I'm gonna allow Dr. Keating to take over.
Thank you, Dr. Kyung, and good evening, everybody. I'm going to walk you guys through the next 2 major cancer topics. So let's jump into colorectal cancer. As you've seen so far, this is another one of our charts diagramming the 3 major task forces and their recommendations based on the screening interventions that we have available to us today. Any of you who have had the joy of going through a colonoscopy know that it is not an easy task at all. And really the worst part is drinking the prep. Also, please know that there are other options out there. But as you'll see on this chart, if you elect to proceed with those options, which we are happy to guide you through in clinic, Those other less invasive options also end up being tested more frequently. And anytime we send you for tests, there's the chance of identifying false positive results. Colorectal cancer can be investigated with something called a fecal occult blood test. You may be familiar with this as a stool sample, in which we take a card with a sample of your stool and we apply a special applicator, and that will tell us whether it's guaiac positive or negative. That study is not perfect, and we are very much aware of that. If you look at the bottom of the slide, we have also addressed that, and there is actually another more sensitive test available to you and that we readily use in the clinic. These are both two alternatives to testing with a colonoscopy. The fecal immunochemical test detects human hemoglobin. The guaiac test does not directly test that. So that's the reason why the former has a less false positive rate and has a higher sensitivity. This fecal occult blood test goes back quite a ways, just like the cervical cancer screening, many decades, and it was the first screening test to reduce colon cancer and mortality by 1/3. This is quite a durable reduction that holds up over 3 decades of follow-up in those patients. So this was quite an impressive intervention, and it certainly has the data to back it up. What about other options? Say you're willing to have an intervention done, but you don't want to quite go for the full colonoscopy with the prep involved with that, but you are willing to get scoped. That's where the flex sigmoidoscopy comes in. As you can probably guess, this is something that we're going to have to do a little more frequently than 10 years. This tends to be done every 5 years with a FIT test. But it, at the same time, is something that you would have to do a little less frequently than the fecal occult blood tests, version 1 and 2 that we just went over. The Flex Sig does have data showing a mortality reduction by 24%. One thing we have to keep in mind, and something that we can often be clued into before we even send you for the study, is if you have proximal colon pathology. If you have a lesion or reason to suspect such that's early on in the colon, we are not going to be able to see that with the flex sigmoidoscopy. And for that reason, we have those patients go for the full colonoscopy tests, because we don't want to miss any track along your colon that could have some lesion, cancerous, or a polyp that could become that in the future. There is also an imaging test for those who can't or would prefer to avoid intervention altogether. They may have an allergy to the anesthesia. They may have a tortuous bowel system. For whatever reason, CT colonography becomes an option in those cases. And that, as it sounds like, is a CT study with reasonable sensitivity and specificity. It's not my first recommendation for patients, but again, it's an alternative for those who can't proceed with the other more invasive involved procedures. As you can see in the middle of the slide, the sensitivity for adenomas, which are a cancer precursor, the sensitivity for finding that in a 1 centimeter and above lesion, which is where we get concerned, is about 67 to 94%, and the specificity is 86 to 98%. And then taking you to the bottom of the slide again, a quick overview of all those screening tests that we've gone over so far. And these apply to anyone age 50 to 75, male or female, regardless of their colon cancer history. As has been reviewed and implied with our previous screening slides, there are parameters where Dr. Kyung and I will send you for more early interventions. And that depends very much in the colorectal cancer sphere on whether you have family members who have had colon cancer at an early age. The general rule of thumb: subtract 10 years from your colon cancer relative who is a first-degree relative, and that's when you should start getting your colonoscopies. So if you have a relative who developed colon cancer at age 50, your target date, and when I'm going to start telling you need to start getting these tests done, is actually going to be age 40 and not the standard age 50 that would go for people without a family history of colon cancer. More recently, some alarming data has come out for early onset colorectal cancer in younger individuals. We have had some high profile cases in the news in this regard that you may have noticed recently. Younger patients have been afflicted with 20% of all colorectal cancers and 30% of all rectal cancers in the past couple decades. And we've taken this data into account and actually bumped up the screening interval as per the American Cancer Society. The USPS task force also has taken this data into account, and they looked at ethnicity. They looked at which populations tend to have earlier onset colorectal cancer, and that task force has identified the African American population as a population that should very much be screened at age 45 and not wait till age 50. Moving on to our next cancer topic, lung cancer. This has also had some excitement of late. We will get into a study in a few slides that is the backing behind what you see on the slide right now. This is a low dose CT chest. That's what the LDCT stands for. And it applies to people who have a past smoking history. As you can see, this is pretty darn similar across the board. No matter which task force you look at, the age range does not differ all that much, whether it's 55 to 80 years or 55 to 74 years. And it's very specific. If you have any trouble, if you want to shoot questions our way, please do. These are the basics right now, and it is a 30-pack year smoking history. You don't necessarily have to still be smoking for us to consider sending you for this low dose CT chest on an annual basis. If you quit within the past 15 years, you are still very much under the microscope to be watched very closely for development of lung cancer. So please keep that in mind. If you quit 10 years ago and you have at least a 30-pack year smoking history and you're at least age 55 or above, we are going to want to send you for annual low dose chest CTs. What about x-rays? That'd be a lot simpler, right? Just send you for a quick x-ray and be done with it. Unfortunately, that has been tested, and they even added a complementary test to the chest x-rays, and they still couldn't find a mortality benefit. So they couldn't find a reduction in the number of people dying from lung cancer based on screening with chest x-ray and sputum cytology on a yearly basis alone. This is why we got to send you for that spiral CT scan. The low-dose spiral CT has been found to reduce lung cancer mortality by 20%. I will get to this trial in a few slides. It's coming right up. It's called the National Lung Cancer Screening Trial, and this is something that came out when Dr. Kyung and I were in residency and has been very practice-changing for the lung cancer screening population. This is an interesting slide here that gives you some perspective about why we favor the CT so much over a chest x-ray. You probably can't see anything here, especially with the resolution on the slide that we've provided. There is a small lesion on there that can be missed even by the most eagle-eyed radiologist who's been training for 20, 30 years. Very easy to miss that spot. If you kind of squint and look closely, you may be able to see a little discrepancy on the x-ray. And then if we look at the CT scan, much more obvious. There's a very obvious white marble-like lesion spiculated on the left side of the lung. Remember, when we're looking at a CT scan, it's kind of flip-flopped in the sense of the right side of your screen is actually the left side of your lung. And if you see that white opacity, that represents a very suspicious lesion on the same patient who very well could have been missed if we just left it at an x-ray and said, hey, we'll see you in a year. Okay, so getting into the National Lung Cancer Screening Trial. This was a large randomized trial of annual low-dose CT screening. We identified patients, and by we, I wish we were directly responsible for this, but it was a nationwide study. So this was centers all over the country sending patients into this study. In order to qualify, you might imagine that based on the parameters we just discussed, you had to be at least 55 and below 74 years of age. You had to have had a previous smoking history of at least 30-pack years, quick primer on that. 30 pack years would be a patient who, for instance, was smoking 1 pack per day for 30 years or 2 packs per day for 15 years. That would get you in the 30 pack year category. And anything above that, we would certainly want to enroll you in this study when it was executed. And as we mentioned before, it includes current smokers, but also those who have discontinued smoking within a 15-year period. It demonstrated a decrease in lung cancer and all-cause mortality. And this was a practice-changing approach. This was a really big deal. And for this reason, anytime Dr. Keeling and I have smokers or previous smokers who come into clinic, we're asking, well, when did you last quit? Well, how many packs were you smoking? It may seem invasive. It may seem like we're throwing a lot of questions at you, but we really want you to be in the best shoes possible. And we want to prevent these things from starting before the cancer develops and becomes much more of an issue and harder to treat. And that's a general theme of what we're telling you about today. The earlier we find these things, in most all cases, with some exceptions in prostate cancer, this leads to a mortality benefit. And that's why we have these screening parameters in place. A little more details about the trial itself. In case you're wondering how many people were involved, over 50,000. And 247 lung cancer deaths in the CT group versus 309 in the radiograph group. So apples to apples were compared in one set of patients who were screened by the CT and other set of patients who were screened by that chest x-ray. We followed this over 100,000 person years. So it was quite a long track record of following how patients did and who survived and who unfortunately did pass away under both of these screening methods. And the relative mortality reduction of 20% is the CT scans benefit over a chest radiograph alone. There is an absolute reduction in 62 lung cancer deaths per 100,000 person years. The number needed to screen in order to prevent 1 lung cancer death was 320. Our problem with this, although that sounds like a big number and maybe you could scoot by and not have to hassle with these scans, we have very little way of knowing who is going to be that one person who is going to benefit. And I would argue that it's much, much worth the risk and the anxiety associated with going with a screening CT each year and having us tell you we didn't find anything or we did and we need to do this. Much rather have that be the case than find a stage 3 or stage 4 lung cancer down the line. Not that we don't battle and cure those, we put up a very good fight with that, but it's just a harder boat to handle. This trial was actually stopped early because we found the results were so good that we implemented it right then and there and said, hey, we don't need to keep following this until the end of time. We've already found a benefit. Let's put this into practice now. Lung cancer is the leading cause of cancer-related death among both men and women. A lot of that is unfortunately due to smoking history and not knowing that nicotine was bad for you several decades ago. There are 234,000 new cases diagnosed yearly, and a good proportion of those also unfortunately are unable to be cured, especially in the later stages. This is a graph, and our main reason for including this is to emphasize that it is important not only to stop smoking, but it's also very crucial when you stop smoking. If you pay attention to the right column and you can see the population that continued smoking, the population that stopped at age 50 versus age 30 versus those that never smoked at all. This is compared to the axis showing the cumulative risk of lung cancer mortality. And you can see that shoot up for the people who continued smoking, but there's also quite a bit of distance between the stopped at age 50 and the stopped at age 30. So it is never too late to stop smoking. It is one of the very hardest things to do. One of the most addictive substances in the world is nicotine, but the sooner you can do it, the better it will be for you.
Okay, so thank you, Dr. Keating. So I'm going to follow his footsteps and talk about prostate cancer, which is another common cancer in men. So prostate cancer is a malignancy that, you know, as you get older, the likelihood of developing it certainly increases. It's very common. Now, the problem is, how do we screen for this? So we do have a way. It's using the PSA. And by checking the PSA, it's essentially a tumor marker that we can check to see if there's prostate cancer. And when this level is elevated, it makes us wonder if there is some kind of malignancy present. Now, the screening for PSA and its recommendation is a little bit more controversial. For example, for the United States Task Force, for men 55 to 69, the decision for PSA screening is actually an individual one. And it's something that you should discuss with your physician and your, and you and your family as well. Because, screening offers a small potential benefit of reducing the chance of death in some men. It's not, the evidence is not as clear cut as lung cancer or colon cancer or even breast cancer, for example. As you can see, same thing with the American Cancer Society. It's a shared decision between physician and patient. It can be checked annually starting at the age of 50 if you're interested, and it's offered in men with life expectancy of greater than or equal to 10 years. The reason we look at the life expectancy in prostate cancer is because compared to some other cancers, we think of, in general, we think of treatment for prostate cancer as more of a marathon rather than a sprint, because depending on the clinical situation, of course, it's one of those things where, if you live long enough, we may be able to find evidence of it. It's difficult to predict who has a more aggressive type and the extent of disease somebody has at a certain age. And of course, treatment does have side effects. So we wonder exactly who benefits from PSA screening, because of course, if we find an abnormal PSA, we're gonna more than likely biopsy and further investigate. And these are invasive procedures. And based on the location, there could be some complications. So it's a lot of factors that, we like to discuss with you and for you to discuss with your primary care physician. So prostate cancer screening is vulnerable to lead time bias, length bias, and overdiagnosis. So this is just a fancy way of saying, sometimes if we find it really early versus, when we find it and life expectancy, all that affects your general mortality and morbidity. How much harm the treatment and the workup can do versus what the cancer can do. And it's all those things that we need to factor in and discuss. Now, when you check a PSA level, and of course the digital rectal exam, it doesn't necessarily distinguish between what's a lethal cancer and what's a harmless slow-growing cancer. Those require additional workup, such as biopsy, and then reading the pathology and looking for certain features on the pathology that may, suggest a certain, personality of the tumor. And of course, the treatments do have complications, impotence, urinary incontinence, and of course, depending on what treatment you get, things as serious as death can occur. So putting all this into mind, in 2018, the United States Preventative Task Force recommended for men aged 55 to 69 It's an individual choice, something that you should discuss with your doctor and see if that's something that you're interested in. Some of the factors that we look at is, anxiety. Some people are a little bit more anxious than others, so they want to have the reassurance. But again, that does come with the possibility of, having to undergo more, even potentially unnecessary biopsies. Sometimes, you are at a higher risk because you have family members that had prostate cancer, or even friends. Friends wouldn't make you high risk, but it may make you more nervous. So, these that we all factor in. So again, we do like to discuss the potential harms and benefits with you, but Dr. Keating and I, as oncologists, we generally see patients that already were diagnosed for the most part. And, because we see how these patients are diagnosed and the circumstances in which they were diagnosed. And, oftentimes our biggest wish is that patients were diagnosed a little bit earlier so that we could do a little bit more. Cancer treatment is all about timing. And the earlier we find something, the better the chance of successfully treating it and potentially even curing the cancer. So, this is why, we also wanted to come and just really go through the screening and really encourage screening for all of you. There are risk calculators available that may help avoid overdiagnosis, and overdiagnosis also meaning over screening in this case, and overly biopsying and overly working things up. So there are things that can predict lower grade or less aggressive cancers. The Gleason score is something that we use to grade prostate cancers based on, the simplest way to look at it is how mutated the cancer cells are. And based on that, if it's more mutated, the more aggressive it can be. And this does help us determine whether or not we should biopsy or watch and wait sometimes. Sometimes we can stratify with age-specific PSA levels, and so which just basically means we can factor into how old you are and what are the risk factors that may be present. And it does help us, determine who should be screened and who should undergo additional biopsy.
Hey everyone, we have front-loaded our presentation today with the most evidence-based screening procedure cancer information for you. Now we have 3 more slides on cancers that don't have as much of a well-supported screening parameters in place, in contrast to breast, cervical, colorectal, lung, and prostate, which have very well-supported established screening parameters in place. So let's run through these fairly quickly as we get to the end of the hour. Ovarian cancer. There is no screening method that has been shown to be effective. This is a very challenging cancer to detect. Physical exam, transvaginal ultrasound, serum CA-125 levels, which is a blood test, they've all been considered and studied to some extent. None of these have been shown to reduce ovarian cancer mortality. For this reason, as a female talking to your primary doctor or your cancer specialist, we do not tend to implement routine screening procedures as a routine basis. There have been a few studies in the US and the UK that have looked at the blood test, the CA-125 level, and the transvaginal ultrasound, and did not find a mortality benefit. What about skin cancers? Screening has not been widely studied in this subject. There are 2 main types of skin cancers. There's melanoma and non-melanoma skin cancers. Melanoma tends to be more of a life-threatening diagnosis. Non-melanoma includes squamous cell and basal cell, and those ones are much more treatable. They tend to be of the variety where you can biopsy and resect and be on your way without any additional treatment in just about all cases. So those non-melanoma skin cancers almost never lead to death. No randomized trial have studied the effectiveness of visual screening in the doctor's office. As you can imagine, there hasn't been a lot of attention drawn to this because if the cancers aren't that deadly in the first place, the impetus to develop screening procedures to catch them early is not that strong. And there are a lot of harms to interventions, even with skin cancers. Even the superficial biopsies can cause problems, bleeding, infection, overdiagnosis, and overtreatment. The USPS task force states that current available evidence is inadequate to determine the risk benefit of visual screening in the doctor's office. And I believe this is our last informational slide, and this goes over lower esophageal adenocarcinomas. Esophageal cancer has seen a big rise over the past 2 decades. Obesity is a risk factor for GERD, also known as heartburn, also known as reflux, which in turn is a risk factor for esophageal cancer precursor known as Barrett's esophagus, which in turn can go on to develop esophageal cancer in many cases. So we've kind of diagrammed this out for you. A common pathway that we see, at least in retrospect, is elevated BMI leading to heartburn, leading to Barrett's esophagus, leading to esophageal cancer. The message here is not that anybody with heartburn and weight that is above the normal range needs to go in and get screening. But there are a few recommendations here at the end of the slide that help triage the patients that we are a little more concerned about, and that you could consider sending them to a GI specialist for upper endoscopy, which is kind of the top end of what a colonoscopy is. So you go through the mouth as opposed to going through the anus. Take a look at the bottom of the slide here. And we have listed a few risk factors. These are based on a society known as the American College of Gastroenterology. These are the GI Specialist Society. They have recommended that men with chronic, which in this case means greater than 5 years of GERD symptoms, and 2 or more of the following: age greater than 50, white race, central obesity, meaning that your adipose cells are concentrated more in your abdomen and your stomach as opposed to laterally on your body. Current smoker or a history of smoking. And the last one is a family history of Barrett's esophagus or esophageal adenocarcinoma in a first-degree relative. If you have 2 or more of these points and you're a man with chronic GERD symptoms of 5 years or more, you should be considered for upper endoscopic screening with a GI specialist. And this is our informational slide once more. That phone number you see towards the top of the screen is the number to our Yorba Linda clinic. We have sites throughout Orange County, but our main establishment is in the Yorba Linda area. And then again, our emails are below. Feel free to reach out to us with questions if you don't think of them right now. But I think with that being said, we'd be open to any questions you guys have for us tonight. Thank you for your attention.
Thank you for that presentation. Now, if you'd like to ask a question, please raise your Zoom hand. You could find that at the bottom of the participants list if you're running a little older version of Zoom, or it's on your control panel under reactions. There's a raise hand button in there now. If you want, you could type the question into the chat room and I'll go ahead and ask the question. So first question is, how close are we to effective pancreatic cancer screening?
That is an excellent question because pancreatic cancer is unfortunately one of the more aggressive, deadlier cancers. It's not, we don't have any recommendations yet. I think that's really it would be great if we can come up with something. You know, pancreas is located in an area where, you know, a lot of luck comes into when it's diagnosed. If it's towards the head of the pancreas, it can cause symptoms early enough that we will kind of know something's wrong and it'll help us look. But if it grows in the more tail region, for example, because there's a lot of space there, the tumor can continue to grow until it's grown large enough that it's really tough to treat. You know, there is a tumor marker for pancreatic cancer, the CA19-9, but, you know, when we recommend screening in general, we are really looking at population as a whole. And right now, we're not that close to developing a good screening method, just because it's not common enough, and just, you know, I hate to say it like this, but just to randomly check a CA19 in the big population, it just wouldn't be cost effective to decrease mortality as a whole. And then if we start thinking about things like CTs, you know, for example, for the lung, you know, the abdomen, there's a lot of organs there that could be a little bit more sensitive to radiation. So unfortunately, I don't think we're quite there yet, unless, you know, I know we're starting to look at a lot of genetics, DNA mutations, things that really, that we know if somebody has a really strong family history, we recommend genetic testing in the family members. And if we know certain mutations are present and it's associated with pancreatic cancer, for example, we do, you know, just monitor a little bit more closely. But in terms of a dedicated pancreatic cancer screening, I don't think we're quite there yet. I don't know. What do you think, Dr. Keating?
I agree with that. It's a very tough diagnosis, and it's tough to diagnose even when you know you have a lesion there. It's a very hard area to get to. BRCA positive patients, they get a lot of attention for breast cancer, but you have to keep pancreatic cancer in mind. And that's where, as you said, genetic screening is very important. There is one precursor lesion known as IPMN, kind of analogous to a polyp in the colon, something that draws our attention. And if you see that 4-letter word on one of your imaging studies, IPMN, in the same way like with breast cancer, it's LCIS or DCIS, these 4-letter words tend to be bad. But it causes us to focus our attention. And in that case, we do pretty aggressively screen for IPMN patients with annual MRCPs, which is a special MRI study and or endoscopic ultrasounds on at least a yearly basis.
Okay, our next question is, on the chart for the lung cancer, why was the lung cancer cases in people who have never smoked so high?
There are a few different types of lung cancer. Squamous cell lung cancer tends to be the one associated with smokers. Unfortunately, there's one known as adenocarcinoma, and that is associated with non-smokers typically. There are exceptions to every rule, and cancer is no exception. But the non-smokers tend to develop the adenocarcinomas. Our treatment approach is fairly similar, I would say, except there are molecular markers that tend to be more present in the non-smoking adenocarcinoma patients. But unfortunately, even though you haven't smoked, there are other risk factors involved that prop up that population of patients, and it tends to be the adenocarcinoma variant of lung cancer.
Okay, this is my year for colonoscopy. I'm on an every 5-year schedule, but with the current public health emergency making me leery, should I tough it out and go ahead with it, or can I wait a few months hoping for a reduction in the seriousness of the pandemic?
That's a good question, and that's something that we're asked actually more frequently, because we do have a lot of patients that require procedures. You know, one of the really unfortunate effects of the pandemic is delay in things like screening procedures. You know, it depends on, I guess, why, you know, your colonoscopy was recommended to be at 5 years, for example, as opposed to the 10. And there are other things that may help you make that decision, whether or not if there's any other findings, whether it's on your blood test or your symptoms that may make us a little bit more concerned. You know, in the general population, a couple weeks, couple months here and there probably won't make the biggest difference, especially in terms of a screening situation. But I think it's something, you know, if we have all the information together, it's something that, you know, it's certainly reasonable. I'm not sure if I give you a great answer, but, you know, it could be done, but it will be good to know if, you know, exactly what they found in your previous colonoscopy, for example.
And just to give it some pandemic flavor, there's a added chore that you have to do with colonoscopies nowadays, and that you do need to get COVID-19 screening within 2 days before you go in to get the procedure done. As if drinking the bowel prep was not bad enough.
Mm-hmm.
Would bouts of painful diverticulitis at age 78 indicate a colonoscopy sooner than 5 years?
So diverticulitis in itself doesn't necessarily warrant a colonoscopy. You know, we do want to make sure you avoid a colonoscopy when you're having these episodes, because, you know, it just potentially, you can have more complications from the procedure itself. But, you know, diverticulosis and diverticulitis. So diverticulitis is basically an inflammation of these diverticulosis, these little outpouchings in your colon. You know, it's not a precancerous condition per se. However, you know, of course, there's always a theoretic concern that with more inflammation, there's just more chances of your, you know, the cells just becoming a little bit more prone to abnormalities. You know, I think rather than just advising a more frequent colonoscopy, I think we would really encourage you to just not miss any colonoscopies.
What is the recommendation for a prostate cancer screening in a patient with a history of prostate cancer in father and paternal uncle?
I think if you, so with a positive family history, such as, you know, paternal uncle and father, and, you know, you yourself, I guess, if it is a man, being a male, you know, I would consider PSA screening, just because, you know, you do have a family history of it. You know, you also want to look at things like the age at which they were diagnosed, how aggressive their cancer was, if you yourself are having any symptoms, you know, and things like that. But how old is this patient or this person again?
I'm not sure.
Okay.
If
yeah.
he types it into the
Okay.
chat, I'll let you know.
Okay. Yeah, but I think with that kind of family history, I think it's something that I would consider getting.
Why don't they check the CA 19-9 periodically in patients who have had pancreatitis?
It's a challenge when you check the CA 19-9. You have to be very careful. Timing is everything in cancer, and there are a lot of cancer mimics. Pancreatitis is one of them. Pancreatitis can lead you along a multi-month track of trending CA 19-9 levels, sending patients for diagnostic laparoscopies. You have to be very careful to let the pancreatitis settle. I would argue that it should be checked. If it was checked initially, having been elevated, you do need to trend that. A lot of things are elevated in the initial acute onset, and we should check that on the tail end to make sure that does downtrend effectively. Because I described a situation where pancreatitis can mimic pancreatic cancer, but the reverse does happen where pancreatitis occurs and the pancreatic cancer is unfortunately missed. We would be happy to work you through that, see you in clinic and help discuss more of the details about whether to proceed with any imaging, a follow-up CA 19-9 level. But at the minimum, I think if it was checked initially, it should be checked on the tail end with at least your primary care physician.
Yeah, usually, when we see pancreatitis, we also look at the context in which it occurred. So if there are other features that we find that are concerning, whether it's weight loss, family history, when things like that come up in that situation, I think it's something that certainly can be considered, but routinely, like Dr. Keating said, it's not something that we check.
In the previous question, the age of onset was 45.
Yeah, so I think Dr. Keating and I would definitely agree that, it's a pretty young age to get prostate cancer. Prostate cancer is a disease of the older population. So when you see cancer at an early age, especially cancer such as prostate cancer, and again, breast, colon, most cancers, it always makes us wonder, is there something going on genetically? Is it a hereditary mutation that's predisposing somebody? And, with that kind of family history, genetic counseling and testing could be considered. And certainly, I think, close monitoring and considering PSA, I think it's very reasonable.
We have a comment that this person had a colonoscopy last May and they had to have a COVID screening back then. So you've been doing it for a while.
Yeah. Unfortunately, with any procedures, you have to get a COVID testing just prior to it, and we've seen a lot of delays in procedures, and it's unfortunate. But if you're at a higher risk, and if you feel like you are, I would just encourage you to just kind of go through the hassle and just kind of get it done so that you can have the peace of mind.
Absolutely.
Okay, I don't see any other questions. Oops, one just popped up. I have breast cancer and my brother died from pancreatic cancer 5 months after being diagnosed. Therefore, my oncologist ordered genetic testing for me, but the 2 times I sent in my saliva samples, they were not able to sequence it. So they are now going to do a blood test. Good. Is a blood draw just as accurate as a saliva test for genetic testing?
Dr. Keating?
They do have similar efficacy. Nothing will be as good as tissue samples, but when you're trying to get an idea of risks in genetic testing, saliva and blood have pretty comparable results. We work with genetic counselors. These big centers tend to work with genetic counselors who walk the patients through the studies, the pros and cons. We actually work with Deepika Nathan, and she's phenomenal, especially with breast and pancreatic cancer. And a full panel is sent. I've done it both ways, and personally, I don't feel there's anything lost from one way or the other. I do saliva, I do blood samples. We work with a couple different companies to do that, and I'm pretty confident that both of them give what you need to know, which is your genetic profile.
Yeah, I completely agree. I don't think you should feel like you're getting shortchanged in any way.
Okay, does anyone else have any questions? Give you just a few seconds to type in your questions. Otherwise, I'd like to thank you, doctors, for giving your talk tonight. It's very well suited to the population that we are at OLLI. So thank you again for that. Okay.
Thank you. It's our pleasure to be here. I hope we were helpful, and please feel free to reach out to either of us with any questions.
Okay, can you put your slide up at the end again?
Absolutely.
Thank you
Okay.
very much for having us, everybody.
Yes. So our next medical series lecture will be on Friday, February 10th at 9 a.m. And it's how to get the most out of your doctor's visit. So that should be a pretty interesting. Part of this medical series that Dr. Lawton has always talked about is you need to form a team with your doctors. You know your body the best, and so you need to be just as vocal with your doctors and help them to come up with the right diagnosis. Okay, and this Saturday morning at 9:30, the Transitions and Retirement series will be presenting shoulder pain, causes and treatment. So that will be another good lecture for you if you'd like to show up. Okay, thank you everyone, and we will see you next week.
Thank you.
Thank you very much, both of you. That was very, very interesting and informative.
Thank you. Thank you for having us. It was really